Let's talk about APLA syndrome, APS. Let's start. APLA syndrome, which is an antiphospholipid antibody syndrome. Let's first start with the pathogenesis. Okay, so if we talk about pathogenesis of APLA syndrome, so as the name suggests, it is an antiphospholipid syndrome, right? So there are antibodies against the phospholipids. So antibodies are binding to the phospholipid. So initiating event, the initial event is antibodies, induction of antibodies to PL binding antibodies, that is antibodies bind to the phospholipid and they make an immune complex. Now when antibodies and phospholipid make an immune complex, the immune complexes get deposited somewhere and then they lead to the clinical features of antiphospholipid antibody syndrome. So any infection, any surgery, any trauma can induce the formation of these immune complexes. So that's how it precipitates. Patient comes with a history कि surgery से पहले everything was okay, but after surgery these are the features that are there, and you find that there is the features are fitting into the criteria of APS or APLA syndrome. APS is antiphospholipid syndrome or APLA syndrome. Then you know that yes, it can be incited by an event like an infection, surgery, or trauma. So this is how the intravascular coagulation and thrombus formation process starts. Thrombus formation process starts, and then it damages all the epithelial and endothelial layer in the vessels, and that is how the main features are there. If we talk about catastrophic CAPS, what is CAPS? CAPS is catastrophic APS, antiphospholipid syndrome, CAPS. If we talk about CAPS, it is a life-threatening. The definition of CAPS is that it is a life-threatening, rapidly progressive thromboembolic disease involving more than or equal to 3 organs at any point of time simultaneously. So a life-threatening event involving antibodies involving at least 3 systems in the body or 3 organs in the body at one time simultaneously. This is known as a catastrophic antiphospholipid syndrome, and this is where we need to go aggressive on treatment. Then there is something known as primary APLA and secondary APLA. In primary APLA, APLA is the only autoimmune disorder. In secondary APLA, it is usually associated with something known as SLE or rheumatoid arthritis or Sjogren's. So if there are features or antibodies suggestive of SLE, rheumatoid as well as Sjogren's along with antiphospholipid antibodies, it is known as a secondary APLA. And with SLE, secondary APLA is very common because 40 to 50% SLE patients have these antibodies. Now, if there is an inciting event like infection, surgery, or trauma, these patients can definitely go on fulfilling the diagnostic criteria of antiphospholipid syndrome also. Now, let's talk about the clinical features of antiphospholipid syndrome. Let's talk about the clinical features of antiphospholipid syndrome. Clinical features of antiphospholipid syndrome. So see, we know that the phospholipids are something that are deposited in the blood vessel, and we know if there is an antibody phospholipid immune complex, it is going to affect the blood vessels first. So veins and arteries. So there are venous events and then there are arterial events. So we divide the clinical features like that. Venous thrombosis, and arterial thrombosis. Venous thrombosis can affect the cerebral veins, can lead to cerebral venous thrombosis, can lead to a deep vein thrombosis in the legs, a deep vein thrombosis in the peroneal veins, can lead to something known as a livedo reticularis on the skin, that is cutaneous vessels, and then Budd-Chiari disease, which affects the IVC, inferior vena cava, which is a clot in the IVC, that is inferior vena cava. And DVT can of course lead to pulmonary embolism. So these are the features that a patient of APLA syndrome can have when there is a venous thrombosis process or coagulation process. Now we need to remember from here that if there is a patient of CVT or DVT or pulmonary embolism or Budd-Chiari, we need to test for antiphospholipid syndrome. We need to test for these antibodies specifically. This is your takeaway point from here. Now we talk about arterial thrombosis. So stroke in the brain, if arteries are involved in stroke, with minor clots there can be TIAs. In the heart there can be an MI. In the fingers there can be digital gangrene, vascular dementia, chronic process because of recurrent clots and ischemic events. Leg arteries में clot होगा तो that will lead to leg ulcers. Renal artery thrombosis, which can lead to young hypertension. So a patient of young hypertension, please also test for the antiphospholipid antibodies, right? There can be fetal loss because of uterine artery involvement. There can be autoimmune hemolytic anemia. So these are the features of arterial thrombosis. So please try to remember the clinical features of APS and divide the features into venous thrombosis. What if the veins have clotting? What if the arteries have clotting? And from head to toe, it will not be very difficult to know this. We left out one, that is retinal artery occlusion. Patient can go blind because of this. So a patient of retinal involvement or retinal artery thrombosis leading to blindness, please go ahead with testing the antiphospholipid antibody in the blood. Now let's talk about how to diagnose. Oh, what happened? Right. Now let's talk about how to diagnose. What is the diagnostic criteria? We know the diagnostic criteria for antiphospholipid syndrome is Sapporo criteria. Very good. So let's talk about diagnosis of antiphospholipid syndrome. So for this we have Sapporo criteria. Right now in Sapporo criteria we should have one clinical plus one laboratory criteria in absence of other causes of thrombophilia. Now what can be the other causes of thrombophilia? Any malignancy can be a thrombophilic state, any coagulation disorder, hematological coagulation disorder affecting PT-INR, APTT can be a cause of thrombophilia. Leiden 5 mutations, protein C, protein S deficiency or mutations. These are the other causes of thrombophilia. If they are not there and there is one clinical and one laboratory criteria, then you can call this a patient of APS. Now, what are the clinical criteria? There are two. One is vascular thrombosis. You have a clinical feature where you have an event and you have proven that there is a clot either in the veins or in the arteries. We talked about that just now, just 1 minute prior. So, for example, a patient of CVT fulfills one of the clinical criteria. A patient of Budd-Chiari fulfills one of the clinical criteria. A patient of young MI fulfills one clinical criteria. A patient of retinal artery occlusion fulfills one clinical criteria. The second clinical criteria is pregnancy morbidity. Pregnancy morbidity. Now, in pregnancy morbidity, we have three things: more than or one unexplained fetal death more than or equal to 10 weeks of gestation. After 10 weeks of gestation. So, for example, in second trimester, there is a fetal loss. So, that is this one. More than or equal to 1 preterm birth before 34 weeks of gestation. So, preterm birth before 34 weeks of gestation. More than or equal to 3 unexplained fetal death before 10th week of gestation. Before 10th week of gestation. So there are only two clinical criteria, out of which one should be fulfilled. The two are: one is an event of vascular thrombosis, which can be involving the veins, which can be involving the arteries. The second is a pregnancy morbidity, and in the pregnancy morbidity prior to 10 weeks, if there are at least 3 unexplained fetal loss or history of abortions, or after 10 weeks, if there is a history of fetal loss or abortion, at least one, or before 34 weeks, there is an alive birth, but it is a preterm birth. But there is no loss, there is no abortion, it is a preterm birth. At least one. So, at least 3 unexplained fetal loss prior to 10 weeks of gestation, at least 1 unexplained fetal loss after 10 weeks of gestation, or at least 1 preterm birth prior to 34 weeks of gestation. Either of these 3 fulfills the pregnancy morbidity criteria. So, one of the clinical criteria is again fulfilled. So, if the patient is having CVT, the patient does not need to have a bad OBS history to fulfill as APS. A patient having a bad OBS history like this one, fulfilling these 3 things, also fits into the one of the clinical criteria. Out of these two, vascular thrombosis and pregnancy morbidity, out of these two, we only need one clinical criteria to be fulfilled. Please remember that. Because what students do is they are always looking for that word pregnancy in question. It may or may not be there, dear. So please remember this in the Sapporo criteria or in the diagnostic criteria of antiphospholipid syndrome. One is one clinical criteria needs to be fulfilled out of an event of vascular thrombosis, which can be a venous or arterial event, and pregnancy morbidity, which are these 3 things we just discussed. Now coming to the laboratory criteria. Now these antibodies, out of these 3, any antibody, so like lupus anticoagulant, anti-cardiolipin, and anti-beta-2 GP1. So lupus anticoagulant antibody, anti-cardiolipin antibody, and anti-beta-2. So or on 2 occasions 12 weeks apart. If the patient has positive antibodies, you need to repeat the test after 3 months, after 12 weeks, right? So 2 occasions 12 weeks apart. If any of these antibodies are there, your laboratory criteria is fulfilled. And now for the diagnosis of APS, you only need you only need one clinical and one laboratory criteria. So here is your criteria. Please remember, try to remember this. Okay. So one clinical plus one laboratory criteria. Clinical is vascular thrombosis, pregnancy morbidity, laboratory 3 antibodies, LAC, ACL, anti-beta-2 GP1. Okay, take a sip of water and we talk about treatment of antiphospholipid syndrome. Let's talk about the treatment. Now, when we talk about treatment of antiphospholipid syndrome, there are 3 scenarios in which the patient can present to you with. One is patient with first thrombotic event, what will you do? Second is a patient with recurrent thrombotic events or CAPS, catastrophic APS. Third is a patient with positive antibodies but no clinical event. So this is how patients can present to you with these three scenarios. Treatment is very, very simple. Please try to remember, divide your patient in whether the patient has come to you with the first thrombotic event along with antibodies, or patient is having recurrent thrombotic events and antibodies, or patient has antibodies but no clinical event. So a patient with first thrombotic event, you have to give lifelong anticoagulation, number one. So lifelong anticoagulation, warfarin plus minus 80 milligram per day of aspirin, and the target INR is 2.5 to 3.5. Now, patient with recurrent thrombotic events or a catastrophic APS, antiphospholipid syndrome, is eligible for IVIG, IV immunoglobulins, 400 milligram per kg per day for 5 days. The name itself suggests that it is an IV injection. Total of 2 grams of IVIG. Patients with positive antibodies but no event, you have to prevent an event. How do you prevent that event? By putting the patient on low dose of 75 to 80 milligram aspirin per day. This is prevention. So a patient who has had a first clinical thrombotic event either involving the veins or the arteries, put the patient on lifelong anticoagulation, maintain INR between 2.5 to 3.5. A patient with recurrent thrombotic events or a catastrophic APS wherein 3 organs are involved simultaneously, for example, a patient has DVT, went on to have pulmonary embolism and also has a CVT, a cerebral venous thrombosis. So 3 organs are involved, lung, brain and the leg vessels. In that scenario, it is a catastrophic APS and you have to put the patient on IVIG. Now, IVIG is an expensive injection, but it is a very good medicine or drug for suppressing the immunity or antibodies, right? So IVIG, total of 2 grams divided over 5 days, IV intravenous. Third is that the patient has come to you with positive antibodies 12 weeks apart but has not had any event yet. Now, as a doctor, you need to prevent that event. So you need to prevent it by giving aspirin. So put the patient on antiplatelets like 75 to 80 milligram of aspirin every day, and that's it. That's it. These are the only 3 scenarios that you can face with in exam also. If the question suggests that the patient has antibodies but has not had any event, you put the patient on aspirin. If the patient is having recurrent events, you put the patient on IVIG. If the patient had one event and antibody positive, lifelong anticoagulation is the answer with INR of 2.5 to 3.5. I hope you got everything about antiphospholipid syndrome. If there are any doubts, you can ask. We will also have live workshops soon, 1 month or 2 months before the exam, so that you can revise. For your revision, we will have that. But go through the notes and also the videos. All right, all the best. Take care, everybody.